Good afternoon, everybody. I'm Catherine Rafelson with SID-US, and we're just waiting for folks to dribble in, and we'll get started in a couple of minutes. If you'd like to introduce yourselves in the chat as you join, that would be great. We're just going to wait a minute or two for everyone to join, and then we'll get started. But please feel free to introduce yourselves in the chat. And once again, just saying welcome, everybody. In case you missed it a minute ago, I just suggested that you could introduce yourselves in the chat while we wait for a few more people to dribble in. We're expecting more to arrive. We'll give it about a minute and then we'll get going. And one more time, just for those who just arrived, we're going to start in just a few seconds here. We're just giving folks a chance to dribble in, and we're just about to start, but please feel free to introduce yourselves in the chat. We'll give it another about 15 or 30 seconds, and then we'll get going. Okay, I think we'll go ahead and get started. So welcome, everybody. I'm delighted to have the opportunity to introduce this session today on mental health matters. Let's talk. I'm Catherine Rafelson. I'm the president of SID-US. I think that many of you know us, but for those who are new to SID, I thought I would just say a few words about us. We are a membership association. We are a chapter of the Society for International Development. We're the US chapter. And we have individual and institutional members who are focused on international development from all sectors. We have NGOs, for-profits, consulting firms, universities, government agencies, private sector firms, students, CEOs, small businesses, large corporations, everything in between. So it's a fabulous and very rich community within which to network. And our primary purpose is to serve as a forum for networking and education. You can see the slide says we serve as a global town square for the international development community, bringing people together from diverse organizations, disciplines, and career stages in a neutral, we're not an advocacy organization, a neutral, independent forum to share information and discuss important issues and challenges facing our community. We do this primarily through events. We have a lot of events. We'll talk about that a little bit more at the end of the session. But you can check out our upcoming events at any time on our website. And in particular, I want to draw attention to an event that's coming up just 4 weeks from yesterday, our annual dinner on November 13th. It's one of our largest events. It's our second largest event typically of the year. Last year, we had over 800 people. It's a fabulous opportunity for networking. And we are going to be honoring this year former President of Liberia, Ellen Johnson Sirleaf, with our award for outstanding leadership. She will be there. She's traveling from Liberia to accept the award, and she will be participating in a fireside chat with former Peace Corps Director Carrie Hessler-Radelet, who's also a former recipient of this award, and it should be a super interesting evening. But one aspect of the evening that I think will be of particular interest to this audience is that we also give out an award to an outstanding young professional at the dinner. It's called the Rice Award, named for the founder of SID, Andy Rice, and it recognizes a young person who has made extraordinary contributions to international development at an early stage in their career. And people apply for this award, and we receive many, many really amazing applications from around the world. And this year's winner was just announced yesterday, and she is actually focused on mental health. It's a young woman from Kenya. She is going to be traveling from Kenya to accept the award at the dinner. And just because it relates so much to what we're going to be talking about, I thought I would just read you the first paragraph of her application. She said, as a young development practitioner, I have always been passionate about working with marginalized communities, particularly in the realm of mental health. My journey in international development has been driven by the belief that mental well-being is fundamental to sustainable development, especially in communities that have faced displacement, conflict, or other forms of adversity. My work has been an exploration of how mental health can be integrated into broader development efforts, creating resilient communities capable of thriving in the face of challenges. She's really terrific, so I hope that if you're not already planning to do so, you will come to our annual dinner to possibly meet her and certainly hear her speak. Things to note about today's event: we will be recording this session and sharing it publicly through our network and social media channels. Closed captioning can be accessed through your individual settings. And if you have questions at any time, actually, but especially at the end of the session, please post your questions in the chat box. And if it's for a specific speaker, please note that when you post it. So with that, I know you're all really eager to hear from our speakers today. So let me introduce our moderator. Bobby Jefferson is Vice President of DAI, and he is also on the SID-US board. He serves, in addition to Vice President at DAI, he's also DAI's Global Head of Diversity, Equity, Engagement, and Inclusion. And he's an extremely active board member at SID-US, serving on our executive committee and as founding chair of our DEI committee, which he chaired until just last month. He's also a founding core member of the Coalition for Racial and Ethnic Equity and Development, also known as CREED. He's co-chair of the Council of International Development Companies, CIDC, Committee on Diversity, Equity, Inclusion, and Accessibility. And he serves on a number of other boards, including Population Reference Bureau and a variety of startups, as well as on the board of advisors for American University. Bobby is a whirling dervish. He seems to be in 20 places at once and is one of the most passionate, compelling, and engaged people I know. As his bio on DAI's website says, he is steeped in the issues of racial and social justice and has reflected on those issues for decades as a professional in the global development industry and beyond. This barely scratches the surface, but hopefully provides a sense of Bobby to those who do not know him. So with that, I will hand this over to my good friend and board member, Bobby Jefferson.
Wow, I like to meet that person. I can tell you that. So thank you, Catherine, very much. Thank you for each of you who are attending and are going to be present and spending time with us over the next hour and a half. So really, thank you for that. So again, I'm Bobby Jefferson, and importantly, this is a topic that's near and dear, which is around mental health. And I want to applaud Sid, both the board and Catherine, for including mental health as part of the SID annual conference last year. And so, you know, making a part of the inclusion efforts is not just accessibility and race, but all the challenges that we have in mental health. And especially if you've, you know, I travel often to countries that are in crisis or conflict zones, so from Ukraine to, Middle East, North Africa, Haiti, and others. And so there's a lot of, issues with families, with staff, and then these are really individuals who are undergoing tremendous challenges of resiliency. And so being able to just have this opportunity to talk through that, I think it's hugely important. So I just want to give you a brief overview to set the stage, which is, so we'll introduce and have a presentation by Dr. Jerome Galea, who is the USAID Mental Health Psychosocial Support Coordinator. And then there'll be some, I'll ask just a few, questions, but please put questions into the chat. So as we're going along, we'll enable an opportunity to ask questions towards the end that he can then respond to. And our dear colleague, Julie and Malvika, will begin to gather up those questions so that we can direct that. So he'll present for 35, or so, 38 minutes, and you'll have a great opportunity to really ask informative and insightful questions. We will then transition into a panel, and the panel will include Dr. Jerome as well. And then we'll invite Ting, and she and Courtney Bickert to give a presentation as well. And there'll be another opportunity for questions and opportunity to probe further around their background, some of their approaches that they've and their lived experiences around that. And then after that, we'll try to give, we will give each panelist an opportunity to maybe answer one or two more high-level questions. So again, we're trying to make this as interactive as possible because we converted from a hybrid in person into an interactive virtual session. And then I would want to leave room at the end for each of the panelists to just give each of you a takeaway. And the takeaways I've found most helpful for me are the ones where the panelists have said, here's what I can do as an individual, here's what I can do as an organization, and here's what I can do in my community. So I'm going to try to keep that time at the end, so that way there's an actual authentic sharing about what each of you can do as well, and be involved. And then lastly, so those who may not know me, please feel free to connect to me on LinkedIn because you're part of this presentation, and I'm inviting you to be participants in the SID community. Just mention that we've met through SID or through the conference, and I will definitely accept, and we can have a further dialogue and communications on this important topic. And later on, I'll just drop in my LinkedIn profile, so that way we can stay connected. So those are all the things as part of the run of show and how the day is planning, the afternoon is planning to roll out. And I do ask one thing of each of you. I know we're doing this remotely, and each of the speakers will turn on their videos, but I really implore that if you can be present, fully present for this engaging and important conversation. I know sometimes we've got many other distractions and things that are going on, but I appreciate that you've carved out of your day and your time. And we have folks who have joined from Jordan and from international. So, different time zones. So just being present so that we can have an interactive, facilitated, authentic conversation going forward. So this isn't a rehearsed sort of, types of presentations. This is more of let's learn together, let's share together, and let's be present together. So having said that, I am so pleased to introduce Dr. Jerome. He is the USAID Mental Health and Psychosocial Support Coordinator and recently appointed. So I think, if he can speak a little bit about his background before his presentation, that would be wonderful. He's a licensed clinical social worker, but as coordinator, Jerome works to promote the integration of mental health treatment and psychosocial support throughout the agency. And he definitely leads the engagement with global partners, governments, donors, local organizations, because that's an important element of trying to address, mental health issues as well in local communities that we serve. So oftentimes, we'll do trips into countries, but it's our communities and our families that are the ones that really take on the challenge of dealing with it. And unfortunately, there is a stigma and discrimination as related to this. And so, we'll talk of ways around how to reduce that, how to address some of the stigmatization as well. And then prior to joining USAID earlier this year, Jerome's received tenure, so I applaud for that, tenure, as Associate Professor of Social Work at the University of South Florida, USF, where his research centers on the global mental health implementation science. So this is, really a world-class individual that you're going to hear from. And so I'm really looking forward to asking some interesting, insightful questions and to give your questions as well. So with that, please welcome Dr. Jerome. I turn it over to you for the next 35 to 38 minutes. Thank you.
Well, thanks for that introduction, Bobby. They get better, I guess, as they go. I really appreciate it. And I appreciate the invitation from SID-US to be able to share some time this afternoon. Bobby, I really like what you said about being present, and it's such a good reminder. And it's so good for mental health too. I mean, I'm talking about the broader issue around mindfulness, but today's space too. I was thinking when you were talking how self-indulgent it feels just to be present in the moment as a community to talk about something that's important to us. And mental health, it's certainly, and especially with COVID, it's really become so much more prevalent in the news. But really, the story of mental health and global mental health goes far back, much longer than COVID. And I know that this is a mixed group. This isn't specifically a mental health group. And so I'd really like to spend my time today sharing with you, well, my presentation is called New Directions in Global Mental Health, but what I'd really like to do is tell the story of global mental health in a three-part narrative. So chapter one is I'd like to carve out and share with you really a definition of what global health is, and I want to throw it out there. I think there may be different definitions of it, but I think when I was thinking about today's presentation, I thought, I could go right into what USAID is doing, and that's so important. And yet, without the broader context, I feel like something's lost. We do mental health for a reason, and that reason is multifold, but it really starts with what is global mental health. So I'm going to talk first about that. From a global movement. And then in part two, I'm going to tackle the larger global priorities and approaches in addressing global mental health. And then the last third of my talk, it will focus on what we're doing and what will be upcoming in USAID's foreign development with regard to global mental health. So let's start with this first question. I've heard, if you look in the literature, there's stories of international mental health, global mental health. But let me just start with how does the World Health Organization define mental health? And their definitions: mental health conditions include mental disorders and psychosocial disabilities, as well as other mental states associated with significant distress, impairment in functioning, and risk of self-harm. And I point this out because notably, it doesn't include specific mention to neurological or substance use disorders. So neurological disorders, I'm talking about things like epilepsy, Parkinson's disease, and so forth. Of course, substance use disorders would be impairment because of regarding use of substances. And so right out the gate, I think that my point here is that the definition is evolving, but it always comes down to significant distress or impairment in functioning, and especially if the endpoint were self-harm or suicide. But back to the original question, what is global mental health? Well, a little bit of history about the global mental health movement is that really, mental health, as I said, spans, formally hundreds and hundreds of years, of course, but in modern history, and specifically the term global mental health, really was spearheaded by this Lancet series in 2007, and this series, which I really encourage you to read, was credited as really consolidating a lot of the work in the area prior to 2007. It was a watershed moment for this field, and this field is really a public health framing of mental health. So it's including mental health explicitly in public health. And I think really before that, it was really mostly maybe a part of social work or psychology, and it still is, definitely, but it is much more broad, and psychiatry, of course, medicine, but it's much more broadened to really be using the lens and the framework of public health. So this series is really worth checking out. And there was a follow-up in 2018, also a decade later. And the masthead for this series was this article by Martin Prince, Vikram Patel, Shikhar Saxena, and so forth, No Health Without Mental Health. And it's really made the case that when we think through other health conditions, they're almost always comorbid, if not always comorbid, with mental health. And this slogan, no health without mental health, is, this saying has really been adopted as a slogan for global mental health. But long before 2007, our own Dr. Satcher, who was the Surgeon General from 1998 to 2002, he said this, and so it's been picked up. And so the idea isn't new, but I guess the case I'm making is that the field consolidated at around 2007 with the Lancet series. So global mental health really is this evolving field, and I love this definition by Pamela Collins, of research and practice, so it includes both, that aims to alleviate mental suffering through prevention, care, and treatment of mental and substance use disorders, and to promote and sustain the mental health of individuals and communities around the world. And I have to say that my own evolution in global mental health really, I became a social worker in the 90s, but it wasn't until about 10 or 15 years ago that I started to understand global mental health. I was working at the time, I had lived 15 years in Lima, Peru. I was working with Partners in Health. Many of you will have heard of Partners in Health. They have a site in Lima, Peru, where I was working. And my mentor, Giuseppe Raviola, who some of you may know, a great global mental health leader and advocate, really got me introduced and excited. And I started by watching this video on global mental health. And so I'd like to share just a snippet of this video by Vikram Patel, who many of you will have heard of. If not, he's a leader, if not the leader in global mental health. There are many leaders. He's a big leader. And I'd like to share with you this video that I remember seeing about 12 or 13 years ago, and it really affected how I saw and conceptualized global mental health. So I'm going to just play a minute of it for you right now.
I want you to imagine this for a moment. Two men, Rahul and Rajiv, living in the same neighborhood, from the same educational background, similar occupation, and they both turn up at their local accident emergency complaining of acute chest pain. Rahul is offered a cardiac procedure, but Rajiv is sent home. What might explain the difference in the experience of these two nearly identical men? Rajiv suffers from a mental illness. The difference in the quality of medical care received by people with mental illness is one of the reasons why they live shorter lives than people without mental illness. Even in the best resourced countries in the world, this life expectancy gap is as much as 20 years. In the developing countries of the world, this gap is even larger. But of course, mental illnesses can kill in more direct ways as well. The most obvious example is suicide. It might surprise some of you here, as it did me when I discovered that suicide is at the top of the list of the leading causes of death in young people in all countries of the world, including the poorest countries of the world.
And so I mean, I got shivers just watching that video again, and it really impressed on me that global mental health is the story of human rights. It's a story of equity. It's a story of disparity, and maybe it really especially pulled on me as a social worker, that yes, it's a story of treatment, but it's also a story of unequal access to treatments that exist. Let me tell you a little bit more about why this is so important. And I'll start by just reminding us what the DALY measure is. So just a quick refresher, a DALY, D-A-L-Y, is most commonly used in disease burden reporting. So that's the years of life lost due to premature mortality, plus the number of years lived with disability. So thankfully, while death is an aspect of mental health, namely by suicide, and is a priority issue, it's still relatively rare. Instead, it's much more common that people live many years with the disability, or YLD. And I'd like just to kind of show this to you. When you look at it this way, so these are years lived with disability for, as you can see, several different disorders. And it's easy to see that if you were to look at just depression and anxiety alone, it accounts for nearly 11% of years lived with disability among all causes of disease burden. I mean, it's surprising, even more than back pain, which is really common. And so it is a story of inequality, but also when you take it in the context of just how common mental health conditions are, and especially mood disorders, and especially depression and anxiety, it's easy to see that this is a huge problem. So let's look at some estimated prevalences. These are data from 2021. Anxiety and depression and depressive disorders, they're the leaders. This is why you hear this come up a lot in the news, especially. But it's estimated if there's around, say, 8.2 billion adults in the world, that's over the entire population of the US alone, around 320 million people, just within, experiencing anxiety. And so we're talking about millions and millions of people. Let's take a look at depressive disorder prevalences. What you can see is the darker color, the darker aqua or blues are where the higher prevalence of depression is, and you can start to see that it's pretty green and blue, but it's the darker colors are in sub-Saharan Africa and LMIC. Keep that in mind as I continue. Anxiety disorders, likewise, you can see that these are common around the world for countries that report such data, and especially darker blue or shades of blue in low and middle income countries, although I would point out US and Australia are also darker blue as well. So this is another thing. Global mental health includes the world, the planet, includes high income settings as well. And so as part of tackling an increasing recognition to tackle mental health worldwide, there was this, as the movement built, the ministers of 194 member states came together, and in 2013 this action plan was adopted by the World Health Assembly with 4 core objectives. So this comprehensive mental health plan, and those objectives really are around strengthening effective leadership, providing comprehensive and integrated and responsive mental health and social care in community-based settings, importantly, implementing strategies for promotion and prevention, and strengthening information systems. And there are a number related key principles. Unfortunately, I could probably do an entire talk about these principles. The important thing to know is that this movement of global mental health has been building and has really taken on an important role in both the UN and WHO, and was codified and buttressed by the Mental Health Atlas. And so what the Mental Health Atlas does is it's a normative tool that comes out every 3 years that's used to monitor progress by the WHO's member states towards the objectives and the targets of that mental health plan that I mentioned a moment ago. So I just want to show you some of the data. There's a new edition that comes out every 3 years. The 24, we're all waiting the 2024 edition. But from the last data, just to kind of give you some more idea, you saw the prevalence of mental health conditions and for depression and for anxiety. Let's look at some of the other metrics used in the Atlas. So one of them is a standalone policy for mental health. So in this metric, mental health policy, would be a detailed plan for the promotion of mental health, prevention of mental health disorders and rehabilitation, and so forth. In total, about 100 of the 146 countries, 86% responded here. And you can see that by and large, most countries have some sort of mental health policy. With the countries in orange are some notable outliers. Let's look at mental health units in general hospitals. You can see here that the deeper yellow to red colors would mean more units in mental health hospitals. So there's patchy data in Africa, but really you can see that units are pretty low, less than 1 in most places of the world, and especially in low and middle income countries. Another metric is the world mental health workforce. And there's much more to be said about this. What I can say is that in the world, globally, only about 1% of the global workforce works in mental health. And in many countries, there's only about 1 mental health person per 100,000 people. And I think what's really interesting in the Atlas is they really break it down by WHO regions. And I just want to point out the Africa region and the Southeast Asian region. If you add up all the numbers here, you can see that we're talking really about around a person per 100,000 people. And so here you really begin to see the disparity in mental health workforce by region. I put in green, just example of the European region, where clearly there are many more people working in mental health compared to low and middle income countries, where in Europe it's when I added up of the 40 countries reporting, I mean it's considerably higher. It's almost 40. Another way to look at this workforce question is by World Bank income group. Again, this just points the picture. If it's a high income country, you have many more healthcare workers on average than low income countries. And so what this really, when you have a high burden of mental health morbidity, but very few people working in mental health, you begin to see the mental health treatment gap, as it's called. I know this graph is kind of hard to read, so I'm going to blow it out for you. Just look at sub-Saharan Africa. What I'm trying to demonstrate here, or what has been demonstrated, is that maybe just around 95% of the people who could benefit from a mental health intervention don't get it. So really only here around 5% of the population in this study received mental health resources. So really, most people aren't getting mental health resources, and so or services. And this is what we call the mental health treatment gap. So I've talked about high burden. I've talked about workforce. Let's talk about domestic spending. So these are just countries that reported in both 2017 and 2020. And the dashed line represent the target percentages by the Lancet Commission in 2018 based on what they felt through research would be necessary for countries to invest in, to provide mental health services equitably across their populations. And there's very little information from low-income countries, but what we know is that if the target's around 5%, really only high-income countries are able to make that spending gap or to meet that spending threshold. And so this is really far behind the Commission's target. And so consequently with this gap, there is a huge shortfall. So again, painting the picture, high burden of mental health morbidity, low prevalence of mental health workers, especially in low and middle income countries, and low health budgets or low percentages of health budgets spent on mental health. But the story, the plot thickens even there. I know this graph is kind of tricky to read, but what I want to illustrate here is that of the spending that goes to mental health, most of it does not go to mental health in the primary care level or in community-based settings. Most of the spending in mental health budgets of countries that were reporting went to mental health hospitals. So more than 60% of the spending among the countries that were reporting went to mental health hospitals. And so what that tells you is that the saturation of services outside of a big mental health hospital is very low in most settings, which brings up major issues for access if you don't live close to that hospital, or if your needs don't require hospitalization. I mean, imagine if for physical health conditions, 95% of the health budget went to ICUs, but there were no PCPs. There was no, there was only really specialized care. I think most of us would go without physical care if our only access were ICUs. And that's how I propose to think about this. Again, here's another look at it from the Atlas. Medium number of community-based mental health facilities per 100,000 population. Again, you begin to see the pattern. If you're in a lower middle income country, you have very little access to mental health, community-based mental health facilities. So, that is a very high look of what the field of global mental health is really grappling with. And it all comes together. So when you combine the high burden of common mental health disorders with constrained funding and a shortage of trained mental health workforce and a reliance on a model of specialized care, well, then we can see a perfect storm leading to this oft referred to mental health treatment gap. And the staggering reality that in most parts of the world, and I would say including many places in the US, especially in rural areas or outside of major cities, the standard of care for mental health condition is actually no care. And most people just go without. And so the field of global mental health really aims to address that disparity and bring to scale across many different levels, which I'll explain now, mental health, quality mental health services for the millions and millions of people that are in need. So I'm going to flip now to chapter 2, and that is, okay, Galia, you've made the case. I'm convinced. There is a big problem here with getting mental health services to all those who are in need. But how do we do that? if there's only, one person, one psychiatrist for 100,000 people, I think most of us would agree that training more psychiatrists is probably a good thing, but probably won't address that mental health gap anytime soon. And so what are the approaches that are primary approaches and themes in global mental health? And I can summarize that with this great diagram from WHO. Integrate, integrate, integrate. And this diagram is the WHO's model network of community-based mental health services. And really, it makes the case that mental health integration, really we can think of as clustering around 3 major nodes and then spreading out and saturating. And I would say it's probably even much more complex than this diagram. But it really looks at mental health in general healthcare, so mainstreaming mental health, community mental health services, and mental health beyond the health sector. And when we think about it, really, I mean, this outside of mental health, this isn't rocket science. I mean, if we think about how regular physical health is in the workplace, it's in construction sites, it's in education, it's in many, many different sectors. We're really trying to appeal to using a similar approach for integrate across as many different services of care, platforms of care as possible. And just social platforms as possible and community-based platforms as possible to really saturate the environment with mental health. And a lot of what, or a primary approach, of course, does include health. This is so important on so many levels. I mean, I think one of the most important reasons why it's important to integrate mental health care with physical health care is that so many mental health conditions have somatic or bodily manifestations. I'm talking aches and pains and headaches, stomach pains, even there are times fainting, dizziness. All of these symptoms can be part of a mental health condition, of course, when organic causes are ruled out. But folks present to their primary care practitioner oftentimes first. They're the first ones to primary care physicians are often the first to talk to somebody who has a mental health need. And so that's why in this model, which is really promoted in the field, you really begin to see primary healthcare providers. They're not psychiatrists, but they can be trained in mental health in the same way that, by the way, primary healthcare providers can manage HIV, but also consult on complex cases with infectologists, or diabetes, but also be able to consult with endocrinologists and so forth, really mainstream mental health into primary care and have it embedded within this broader environment of community-based services, but keep the specialized mental health services as a backup for those most in need. And this WHO service organization pyramid, many of you will have seen, but I like to repeat it because, again, most mental health spending goes at the top of the pyramid here, but really the frequency of need is very, very high at lower at the base of the pyramid here. This would include things like self-care, informal community care, even primary care, I would say, which cost much less than spending money on these quite expensive mental health institutions. And so, using these as our guideposts, the next big program that was launched, again, by WHO with many other partners is the Mental Health Gap Action Program, or called MHGAP. And hopefully many of us know about this, but I want to tell you a little bit about it and then invite you to check it out. It includes I would say two main branches. One is these MHCAP algorithms for general medical doctors. So these are doctors that, they're not specifically trained in mental health, but they can be trained to manage common mental health conditions, following standard algorithms, which physicians will be used to following for lots of different medical conditions. And, in this particular one, to show you, this is just what it might look like if you were a physician. Really, it coaches the physician on how to manage, how to assess depression, when to rule it out, when to think it might be something else. And really goes through a very careful decision tree. Of course, there's an entire training that goes with this. But my broader point is that physicians may feel uncomfortable in the beginning, but can treat with a consultant psychiatrist many common mental disorders. And for more complex cases, they would then go to more specialized services. So that is a key initiative in the global mental health movement. And so when you're training physicians, that also means you have to have access to the appropriate use of medicines for mental health disorders. And so broadly defined, access to medicines for mental health disorders, these are sometimes also called psychotropic medicines. This would really encompass the rational selection, availability, and affordability for the appropriate and voluntary, the case of the patient, use of those medicines. And I would just say that there are many places in which even the most basic, say, anti-anxiety medicines are not readily available, especially for things like, epilepsy, where there are safe drugs that don't require regular blood testing, especially for child epilepsy, which in these cases often present at primary care facilities first. So improving access and getting these medicines on the essential list, or getting countries to adopt those essential lists, is also essential. I mentioned that besides the mental health algorithms for physicians, there's also these low intensity psychological interventions. And these interventions, these are 5 of the WHO interventions. These interventions can be delivered by people with no previous mental health training. So think community health workers. They've all been tested in randomized controlled trials and mostly require surface adaptations for local contexts. There are over 100 countries using these interventions. You may have heard of Problem Management Plus. That's the one on the far left. It's been adapted and used in many different countries. I've adapted with colleagues in Peru, both PM Plus and also Thinking Healthy for perinatal women. And these, when I say surface adaptations, what I mean to say is that the core ingredients have been tested across many cultures, but they will require some adaptations and presentation, sometimes language as well, so that they fit the setting. My broader point is that these interventions exist and they work, and a big goal is getting them scaled. The WHO also has a number of other publications on mental health integration into existing treatment platforms of care. So think HIV, tuberculosis, and so forth. I just want to mention, I won't go into detail, that a big challenge in global mental health really isn't designing new interventions. I mean, the interventions we have can be improved on, and there is a space for that. But there is a huge time lag between getting what we have already that works into the field and adapted. And I just want to mention that I'm glad to see that places like Partners in Health, with their mental health chain for, mental health service delivery, is one model for integration. There's also the 8 C's model of collaborative consultation for mental health and psychosocial support. My broader point here, though, is that there are now emerging models because, it's hard to take a manual and just, roll with it. It's much easier if you have step-by-step, a recipe and guidance. And there are a few that I would recommend. And I always have to say that it's more than just scaling. We also need to ensure competency. We need to make sure that these interventions are available, but they're being delivered with quality. And so I like to mention this free online platform called Equip. And Equip helps train the mental health workforce. So these would be non-specialists in acquiring the skills necessary to deliver psychological interventions. It's also been used, I'll note, more recently I've heard police, with physicians and nurses. It's intervention agnostic. You can sign in and sign into the Equip platform, create an account, and continue learning or learn there. Okay, so what are some of the other key issues in global mental health? Well, suicide is definitely probably the worst outcome in mental health when mental health morbidity goes unaddressed. It's a huge problem. And while it's reducing in prevalence in some countries, I'll point out that in the Americas, including the United States, the incidence of suicide has risen over the past decade. Still, 80% of suicides occur in low and middle income countries, but there's very little research that happens in those settings. Suicide as an endpoint is also one of the UN Sustainable Development Goals, to reduce suicide mortality. I point out the Live Life intervention. This is Live Life. I just mention it because it is an initiative by WHO. You'll notice I talk a lot about WHO in part because they're the world leader, but because USAID is also quite aligned with and supports many of these programs, including Live Life. And I invite you to read more about the Live Life initiative. But what I really like about Live Life is it takes a public health approach in reducing suicide. And one of them is reducing access to most lethal forms of suicide, because oftentimes in the moment, if you can reduce access to the most lethal form of suicide, a person has time to kind of pump the psychological brakes and doesn't have to end their life. And so by limiting pesticides, I thought this was a really interesting study in Sri Lanka. Well, this one is on Nepal turning their tide on pesticide, but really also in Sri Lanka, if you look at when pesticide reductions were introduced, suicide rates plummeted. So, that is one way that we're working, among others, to reduce suicide incidents. Another barrier to suicide, in meeting that goal, the 2030, Sustainable Development Goal, also includes another structural intervention, which would be to remove criminalization. Criminalization doesn't lower suicide rates, makes it harder to seek support, and likely does more harm than maybe the good that those laws were aimed to is set out to do. But it's still suicide still remains criminalized in 23 countries. Okay, rapidly moving forward, deinstitutionalization is another big global mental health movement. I mean, I mentioned that because we're talking the top of the pyramid, but in many, many places, these large mental health institutes are the only institutes that exist for mental health care. But many, many people are chronically institutionalized with mental health conditions that are well under control, and they could be living in their back at home if their home exists. Oftentimes, folks are socially abandoned. So we'd really promote community-based care, safe houses, and so forth. climate and mental health is also a major mental health, a global mental health initiative. It's more than eco-anxiety. We're talking about displaced populations. If you are in the US, you know about the mental health morbidity. It's been in the news. We've had 2 major hurricanes in the US. So exposure climate disasters definitely affects mental health. I will say it also disproportionately impacts the mental health of children, adolescents, and especially girls, by disrupting education, social support systems, and overall emotional well-being. Some of the other key areas are digital solutions to mental health, and digital solutions hold promise, especially in that bottom pyramid, so increasing education, linkage to care. There's also some emerging mental health models using generative AI, which I won't comment on, but just yet, because I'll say they're emerging. But it's an exciting new area to really not necessarily replace humans, but bridge the gap. There are some people that just don't want to talk to a human and want to first get their information from a chatbot. And the example here in the video that's playing some work with colleagues in Lima, Peru, to design a mental health chatbot for education, self-help, and care linkage for adolescents with HIV in Peru. Okay, and now I want to rapidly go on to mental health stigma. I really can't give a talk without mental health to talk about barriers to mental health and how mental health is just treated so differently than most physical conditions. And I think these cartoons, make the point that for most other, for physical conditions, you would not see people saying, well, you just need to change your frame of mind, you'll get better. And so what mental health stigma does is it really is a corrosive force that prevents people from getting care that they could benefit from. And so there is another Lancet Commission on mental health stigma that I encourage you to check out from 2022. And it is definitely one of the biggest barriers we find that hampers successful care access and delivery. But I would also mention that there are evidence-based mental health interventions. So oftentimes my other, beef is that we talk about stigma as if there's nothing we can do, or that is bad, and it is. But I would encourage us to also think about scaling up interventions like Honest, Open, Proud, which is a evidence-based intervention that uses contact-based, so contact with people to really reduce stigma in mental health. That is the executive summary of the key issues in mental health. There are, in global mental health, there are others, but those are the ones that you see come up the most. And that leads us to the last few minutes of my presentation is, what is USAID doing about this? And how are we really contextualizing mental health, and why is it important in foreign development, and what are we doing to steward this forward? So I hope I've made the case why this is so important just globally. I've talked less about why this is important in development, although I'm hoping that since this is SID, that most of us will understand why this is important. But I will just make the first and the case that I always make is that failure to address mental health is often this, if not a hidden barrier, then an explicit barrier to achieving our development and humanitarian goals. And why is that? It's because, mental health impacts physical health, young people's health and development, education outcomes, economic security, workforce participation. These are all the things that USAID invests in globally. And so by investing in mental health, we would expect better return on those investments. In fact, a really interesting study here is this modeling study that just looked at cohorts of adolescents that were followed from 36 countries to assess the impact of what return on investment would you get if you were addressing anxiety, depression, and bipolar disorders and suicide during adolescence. And it modeled out, what we would expect over the lifespan, so over 80 years, okay? And what this study found was that for every $1 invested in mental health for children and adolescents, we could expect to get around $24 back in the benefits. And the best part about this is that the highest return on investment were exactly in the countries where USAID focuses work, in low and middle income countries. So that takes us to the crown jewel of the USAID's mental health program, which is, I won't say it's new, but it has been really elevated in the past year, and especially past June, when we launched our mental health position paper, which really spells out how USAID, and you're welcome to scan the code there or just Google it, and really spells out our approach to mental health and how we see mental health as expansive and really capturing many of the these core components of the human experience: emotional, cognitive, psychological, and social well-being, including how we think, feel, learn, and work, make decisions, and build relationships. And we really view mental health across a continuum. We do not view mental health as a binary, a binary condition. Either you have a problem and you go to a hospital, or you don't. No, mental health is a continuum. And as the No Health and Mental Health Lancet paper said, we view mental health as protean, as something that is interactive. It waxes and it wanes, just like physical health. Some days we feel better than other days, but we're not always going to the doctor. But when we get, we feel that we need a medical intervention, we do. And so, and it's really determined by health, physical health, social supports, and culture. And so when this paper was developed, I just want to say maybe some of you were part of it. It was consultations that lasted 2 years, 39 countries, and 200 people, in which they landed on this. If I ask you to remember of anything, the heart of hearts of the USAID mental health position paper is this tripartite approach that looks at promoting sustainable environments, applying contextually appropriate approaches, and do no harm, all surrounded by addressing key barriers, strengthening and diversifying partnerships, and fighting stigma and discrimination. And so I just want to end my talk by showing you some of the things that our mental health team is doing. So what we're really doing this year is gathering steam, getting our tools together. Here are just some that are available now, but I'm really excited to say that we're also developing a number of how-tos, sector briefs. I mentioned integrate, and that's what our team will be focused on in the coming weeks, months, and years. So we have sector briefs on mental health and education, gender equity, WASH, economic growth, health, research and science, climate change, humanitarian aid, and many more that are in the works, to really give very specific guidance on and technical assistance on mental health integration. I just want to now wrap up with some examples of things that have been happening. I have to say, USAID, while we're elevating mental health, I want to be clear, mental health is happening in missions around the world. Just back from the Philippines, where I learned about the Kata Tagan Plus, which is a version of PM Plus that's been, I would say, seasoned with Filipino spices. It's evidence-based intervention. They also developed a digital intervention. I also want to mention that for many years, the Victims of Torture Fund, which is part of the agency mental health team, has been conducting mental health programming in many, many different countries for this special population. Also, the Global Health Bureau, I mean, I picked one. There are many things that Global Health Bureau has been doing, specifically in disease and mental health integration, like TB and mental health, but also PEPFAR and mental health. Another program, again, this one is funded by the Victims of Torture Fund, is Weaving Lives and Hope. So I'm just giving kind of call outs. I apologize if the program you know and love isn't here. I'm just kind of showing what we have available to date. We have other resources like the Psychosocial Resource Navigator that allows users to search from a catalog of evidence-based mental health interventions and assessment tools and other resources. So many of these are already available. We're working on refreshing our website to make these more accessible to the public. And I think with that, I'm out of time. As you could probably see, talk about mental health all day, but I'm going to stop there and hand it back over to you, Bobby. Thank you.
All right, thank you. What a wonderful, fascinating presentation. And if everyone, can give little applause and hearts to Dr. Jerome, this would be wonderful. I found this to be fascinating. And so what we'll like to do while we're doing that is there's a few questions that came up during the chat, and my questions you were able to address during your presentation. So thank you for that. So I'm going to ask Julie, because I can't scroll back as far. If you can ask or just recite the 3 or 4 questions we received from the audience, and then Jerome, you can select which one that you want to choose to select to answer, and then we'll transition to the panel, and we'll save their other questions that wasn't addressed until the end.
Yeah, can you all hear me?
Yes.
Okay, so I'm going to read them out, but I'm also going to copy and paste them into the chat so you can see them, Jerome, as well. So first off, we have, what can we learn from decades of integration of HIV-TB integration, and how can we accelerate MH integration? That's the first question. The second is from Sandra, and Sandra asks, any insights or best practices related to supporting our teams as well, especially those working under difficult, stressful environments and or with trauma-affected populations? And then finally, Nilufar from FHI 360 asks, how do we facilitate transition of services from inpatient to outpatient MH in the context of constrained budgets? Is there a model of efficient and effective outpatient MH worth replicating? So those are the 3. Looks like more are coming in, but those are the 3.
Sure, and I'll be brief, and I just want to invite people to also feel free to send me an email afterwards, and I'd be happy to talk more. But and we have other speakers too. Let me give quick top level answers. I'll start with the decades of integration of HIV and TB integration. What I would say is actually still a long way to go in both of those platforms. But what it really shows, I think my first thought is that these are a excellent examples of kind of proof of concept of how existing care platforms where mental health morbidity is especially high, because these are populations that are especially vulnerable because of these health conditions. And what we can learn from these is some of the lessons learned just in my own work in mental health and integration is that some of the barriers really begin with the structures and what we're working with. And I think the first concern is around adding yet another task to an often overburdened healthcare system, frankly. And so I would say the best thing that I would say for this is we've learned that you don't have to start from scratch. Start with existing implementation science tools. I like CFIR, the consolidated CFIR, the Consolidated Framework for Implementation Research, that has a complete model that would guide people from beginning to end to how to implement a new service. It is not one size fits all, but many of the issues are common across services. So I know that's somewhat generic, but what I would say is that it's a really good example of how this can be done. Shall I take the next question, Bobby? just move to Sandra's?
We'll save the next question until we finish the panel Q&A, and then that
Okay.
way there just may be a few more as well. But thank you for that.
Sure.
That was very helpful. And what would be also helpful is, as we're going through the panel, if there are websites. So for example, the Honest and Proud, Out and Proud one, I dropped into the chat, but if there's websites that we can just easily drop into the chat, I found those to be very helpful for interactive audience to just review.
Sure.
So, but thank you for that. So again, thank you very much. This is really fascinating. Learned a lot as well, and we're going to continue this conversation. So I'm glad you mentioned around some of the digital and some of the AI and technology and the work you've done in Peru. So I'd like to now introduce we're going to convert to a panel format. So if Ting and Courtney can come on their video, I just want to do a brief introduction to Ting. So Ting Chi is the founder of ClickMedics. And ClickMedics is an award-winning health tech social enterprise born out of MIT. MIT, wow. And the vision and mission of ThinkMedics is to enable health organizations to serve more patients through telemedicine and population health management. I believe there's a platform. But what's been impressive about Ting is that she's been an award winner for the Cartier Women's Foundation. She holds an MBA from MIT and undergraduate from Carnegie Mellon as well. She's been in a number of countries. She and I visited, Jordan and cancer hospitals together. So she really knows how to do, global mental health telemedicine from on the ground perspective. And importantly, how to support our community and health workers, our outreaches, our nurses, both the US and domestically. So that's part that I really like, is being able to address both while using AI and all these fancy tools to help better the health outcomes. So I'm going to turn it over to Ting. But before I turn it over to Ting, I just want to quickly introduce Courtney. Courtney is another fantastic person I've known for a long time in the global mental health space. And actually, Courtney is a stand-up comedian. So even though Courtney has been around in international development for many years, we've been together, and she's got a very positive social impact. There's also, I want to leave, and have room for a positive conversation around the use of curiosity and humor. And so she's the CEO and founder of Laughing Matters, which tries to really help instill humor and laughter. And so she does stand-up comedy as well. So if you're you're in DC, you want to catch one of her shows, that's fascinating. And but this all addresses not just the issues of mental health, but how to, as an individual and as an organization, being able to address these types of issues. But first, we'll turn it over to Ting for her fascinating presentation. We'll leave a few minutes for Q&A for Ting. Then we'll transition directly to Courtney. And then from Courtney, there'll be a few questions. And then we'll invite Jerome back, and then we'll continue with the Q&A session. So hopefully that's clear. Thank you, everyone, for continuing to being present. Thank you for continuing to put your questions in the chat. This webinar and session is really about each of you. So please, let's keep it going. So with that, I really turn over to my honored colleague, Ting.
Thank you, Bobby, for the introduction, and thank you everyone else for continuing to stay in this session. And thank you, Dr. Jerome, for laying a really thorough understanding of global mental health and the problems and some of the root causes we're dealing with. And one in particular near and dear to my heart is really the lack of access to care. And even if you had access, it's, you mentioned 1 to 100,000 in some countries, even more in others, and lack of funding to address this serious issue. And when I founded my company out of MIT more than 10 years ago, it was really to address the problem of lack of all the ones that we mentioned. We started working in Botswana, taking a problem that seems quite simple. There's one oral surgeon for over 1.8 million people. And for something like oral cancer, which you can see here, the patient is sticking out her tongue. You can see the white lesions. For someone who is trained, it is very obvious, very easy to identify. There's a problem, it's likely oral cancer. And then sending the referrals to get to an oral surgeon to confirm that diagnosis. What we recognize is that this knowledge, if provided with the right information, can become a diagnosis and treatment, as well as education and instructions for the local healthcare teams to address the problem, therefore solving the problem of one specialist for over 1.8 million people. And what we did further is to say, can we systematize this kind of solution structure into a software solution so that it can be done repeatedly and adapted for different countries, different diseases? And to kind of simplify the method involved, one is obviously screening, which could be through images, could be using a mobile phone that can work offline, taking an image, and then asking the same type of questions a doctor would have asked of the patient. So sort of having a health worker read off the script that the doctor would have asked, and therefore it's almost like having a doctor training the health worker, coaching the health worker through to collect the information. Then diagnosing initially would be a remote doctor doing the diagnosis, but as I showed earlier, with something like a white lesion on the mouth, on the tongue, it's very easy to train a local nurse or a local primary care doctor to start recognizing, oh, that's cancerous. This is how I can remove it. This is how I can treat it. And eventually may not need the remote expert and actually building capacity in country. And then the most important thing is certainly following up cancer tracking in terms of making sure that they follow up with the care, that it doesn't reappear, and so on. And this works just as well for other diseases, as we found. Can we use the same methodology and show that it can work for other issues? So as Bobby mentioned, we worked in Jordan with King Hussein Cancer Center. And this is one of the programs where we say, can we take something more complex, the chronic disease, patient has cancer, and adopt the same model? And here what you're seeing is a nurse and a health worker both doing a home visit. The health worker in blue is operating a tablet that has these questions that mimic what oncologists would have asked. And if there are any questions during this process, they can then remotely contact the oncologist for further suggestion. And at the same time, with mobile technology, you can add information like blood pressure and vitals. All of this you are familiar with, and transmit all of that into a full record that the doctor can review and come back with advice. So none of this is really new. It's telemedicine plus chronic disease management plus tracking of the patients over time. And we've done this in 25 countries, addressing all sorts of different diseases, and realized what we're learning from emerging market, low and middle income, can be used really anywhere, including the US. And when we use this in the US, what we realize is there are a lot of senior aging population in the US, and diseases are even more complicated. We work with Medicare and Medicaid programs in the US. On average, a senior may have 11 diagnoses/diseases, and therefore really stress testing the methodology and the platform, whether we can service patients in the same way, screen them, follow them through, doing home care if needed, remote consult with doctors if needed, and figure out how to care for them. And to kind of package all these together into lessons learned, and also, in terms of use of AI, number one, no matter what you use, you need to have the right diagnosis. You need to help the patients also learn about their condition, especially when it comes to mental health. They need to understand what it is. They're not alone. It is a disease. It could affect them in many different ways. And then finding the right providers and different health services that are available to help. And as Dr. Jerome said, integrate, integrate, integrate. This is not the first time we're addressing mental health or any of the diseases. There are many underground organizations that have deep expertise and manpower to do so. We need to connect them, maybe building a knowledge hub to know who they are, what they do, which patient could we refer to these areas. And I think the third part is identifying, as far as mental health goes, what does the individual need? What are the barriers? Is it other health conditions? Is it other social determinants of health? They may not have transportation, access to food or medications. or maybe they're low income. Maybe there isn't a good family support structure to help them deal with various diseases, including mental health, could be environmental, financial, or legal. And I think one other part, going back to integration, is building a team around the patient and around a program for everything that patient may need and that population may need to get the help that they need. And one other thing that's very important that we've seen everywhere is setting up an accountability mechanism. The role of health coach can really, really not be understated. They provide that accountability mechanism. They provide that peer/authoritative or knowledgeable person where the patient could share mental health issues and other issues with that person. And that becomes a buddy system or accountability that we've seen work over and over, whether it's anxiety, depression, mental health, or diabetes, and a number of chronic diseases. And obviously tracking the progress. And I think one of the most important thing is, as we work across 25 countries, what are the best practices? They're really not the same everywhere, but how can we capture them and develop more of a standardized approach for that population to help train the trainer, to help treat the patients, and to help elevate and scale and identify where we can automate. So next, I'll take you through an example of a program that we implemented in California. This is the California state-run program called Enhanced Care Management. What they've identified is those that have mental health problems, alcohol, drug abuse, those who were incarcerated, those who were low income, have a variety of problems. That's not just health, and mental health added to other health problems become huge cost burdens for the state of California. And what they develop is an ECM program, which you see here, whereby it's run by psychosocial support services and community clinics that have counselors, psychiatrists, psychologists to help with these populations. And they get follow-up services, they get education on the medications they're taking, they get help with booking their appointments, transportation, identifying social determinants of health, such as food problems, housing problems, and connecting them to existing community programs. So it's everything we talked about in terms of what are the support pieces we can put around the patient. And in the state of California, they're rolling it out as a program. So far, there are over 80,000 patients who have joined the program, over 1,000 providers. So talk about integration, everyone coming together to deliver this program and to enhance and scale this program. And I'll skip over some of the details, but all of this you're familiar with. It starts with outreach into the patient. It starts with developing a care management plan, coordinating the care, training the patient on what their conditions are, particularly with mental health and what they're going through. Transitional care in terms of moving from hospital out of the hospital, where there are a lot of cost reductions. And that's also what the program is measured on. How many expensive hospitalizations can we avoid by adding support structures, psychosocial support, and addressing mental health problems in this very vulnerable population. So we use the same method, screen the patient, determining a risk level, and then getting the care they need. And in this case, is usually non-doctors, usually counselors, and really addressing that psychosocial support, that community care portion, and then setting a plan forward. And the system, as it goes through, and we call it care planning, it starts to learn. So now we're at the point where we say, patient who's 20 years old, has drug and alcohol problem, recently incarcerated, has no family support, what can we do? And the system would generate the care plan that addresses every one of those issues. And this is because it's learned from experts who have dealt with these problems thousands of times. And of course, it's supervised by the counselors to make sure this plan, the AI generated, is viable and continues to learn from expert feedback on these planning. So here's an example of one of the portions, is to figure out what are we dealing with, what is this patient? And it covers everything from their current medications to their social issues, barriers, health conditions, including legal involvement, community needs, and many, many others. Also addresses issues for teens and children. After that comprehensive assessment, then this is the semi-AI automated care plan that identifies the problems, and the various issues, goals, interventions, and very quickly be able to develop the personalized care plan that would help that person, and obviously following up through both human-based and automated reminders, intervention, depending on what those are. So we are also figuring out, while AI, not generative AI, we're not trying to replace a person and converse in such ways, but really looking at what is the human doing that the human doesn't need to do, such as filling out paperwork. That's one of them. But when it comes to care planning and communicating that care plan and convincing the person to change their behavior or address their social needs and mental health problems, where does the human come in? Where's the art and science of it, and trying to balance that? And we do that by building an AI knowledge hub that takes expertise of the different specialists and also the experience of taking patients through this process and really understanding what are the services that could be available, what are the ways we address the people's needs uniquely. And similarly, another program in the US that is nationwide is addressing dementia. They're a very similar model, and this program has learned over the past 2 decades of what's working, what's not working, and you'll see the very likelihood and similarity in terms of assessment, care planning, providing support. What's interesting about dementia care is that the caregivers, 39% of those caregivers suffer from depression. So it brings on another problem of not only are we addressing depression, anxiety, and mental health problems of patients, but also caregivers suffer from depression and anxiety by providing care and the stress that goes along with it. So it's not just one person a lot of times, it's 1 + 1 and whoever else is involved in terms of what we need to address. And what's unique about this program is a lot of it has to be our solutions for the caregiver, because most of the time the patient has dementia, can't really function on a daily basis, and therefore giving that support to the caregiver from based on knowledge and training on what to do to care for their loved ones, and understanding the dementia behavior, and then care navigating in terms of referring them to community-based resources or even paid resources that are available. Again, same process we've implemented to prove that it does work, and even extending into other particulars and tailoring it to dementia patients, which involve things like home safety. And providing a chatbot where we are allowing caregivers and patients to access a knowledge base on what is the correct thing to do, how do you know what to, dietary constraints, and how do we help the person have normal daily activities of daily living, so on and so forth, using an app to enhance that in the US. And lastly, how can we take all of these learnings, these existing programs, these new programs, and implement it in other regions to address this major problem of global mental health? And having worked in so many places, is to identify the resource constraints. Some low middle income countries may not have the necessary infrastructure connectivity. There are not enough hospitals, there are not enough doctors, and funding to address all these. But we know there are local expertise and resources, and many of them being developed by WHO and USAID to try to extend that knowledge and expertise, as well as best practices that can be implemented through community-based services and different methodologies and health promotion mechanisms. And then lastly, to scale, there's certainly things that can be automated, such as outreach calls or scheduling and follow-up, telemedicine, and training on best practices. And all of that could contribute to building a unique knowledge base that could be different by different countries and regions as to how is the most effective best practices to addressing those mental health needs in those regions, as well as who are the community providers who can do that, to really try to put in the best methods forward and scale those working solutions. So I welcome the questions you have, and thank you for the opportunity to present.
Thank you for that, Tim. It was very practical to understand some of the interventions to help support the caregivers themselves. Just a quick question before we transition to Courtney. because you mentioned about specifically dementia. And so how does some of these tools, such as AI and the platforms, how do they apply in resource limited countries where there's a conflict, whether or not it's Ukraine, Haiti, or Middle East? How does that work? Like, do some of these tools that are developed in the US and are proven, can they be applied or should they be applied in international settings?
I think it's certainly a hybrid approach. So the first thing in any country is to understand what's working locally. What are the nuggets of learnings for those countries? For example, conflict zones. What's working to address those problems? Is it a particular community-based counseling process? Can we replicate that and extend that to the bigger areas of the region? And then therefore capturing the how-to into the AI knowledge base so that they can be queried and easily into other areas. And I think a second part is in terms of just automating things such as auto-populating documents, patient records, and things like that, and scheduling and connecting patients from rural areas to the knowledge center. And I think the third part is really training and education, training the trainer after you've identified the expert in the area to address this issue. Who else can they train? What community organizations could be trained to continue this expertise and reach more patients in need of this type of services?
Great. And there's one question, thank you, Eric, from the participants, which is the personalized care plan all generated based on the algorithm by AI, or if there's any human involvement or review in the generation of the care plan?
Yeah, before we really AI anything, we start with the humans who are the licensed expert in terms of developing care plan. We actually started with literally a spreadsheet that says, here's the problem, here's the goals, here's the solutions, here's what I as a licensed professional who's done this over 20 years would do. And then based on that, we look at, okay, let's take 10 of the best professionals, look at their care plans, mesh that together with the patient's characteristic, and say, okay, AI, based on these learnings that you've taken from all these experts, what would you come up with? Then the experts say, okay, is the AI right? Is the AI wrong? How can I improve on that AI care plan? So it's definitely an evolutionary process, but it happens very quickly. Could be 2 or 3 months when the experts have done the human version of the care plan into an automated version, and very quickly the human tries to improve the AI, and then it can be on more automation. Then it becomes more of a QA, seeing, making sure the AI plan is accurate, and therefore reducing the time that's needed to generate those care plans from hours to minutes.
Great. So we're going to transition quickly to Courtney, but before I do that, I want to say, just based on my experience of trying for many, many, many years on the HIV program, TB programs, trying to capture the clinical patient interaction, where the physician, she's filling out her SOAP notes, she's interviewing the patient. I mean, you have 300 years of medical training, right? You need to interact with the patient. And then trying to get the physician to fill out the forms, the SOAP notes, all those things. And then, of course, the coding that's around that has always been a challenge. And so I see a lot of promise in a lot of the new tools, whether it's AI tool, Dragon tools, where everything's just on a phone. And the AI tool is silently, ambiently listening to the physician-clinician-patient interaction. She's going through the process, capturing all the notes, but it's being captured in the tool. And then the clinical SOAP notes, along with the electronic form, is automatically filled out. Or even reminders are asked. So sometimes, some of the physicians may skip, does a patient have an allergy? And so if you skip that question, does that mean the patient doesn't have an allergy or didn't ask? And so, having some of these tools that are just a phone on the desk in a room where you're interviewing patients and it does, filling things out automatically, for me is a game changer. I've spent many, many years trying to deal with data quality capture in forms, or, describing, prescriptions, and it's, and the drug isn't available. So you got to find the generic brands and all those things. I completely agree with you that this is, a potential game changer, capturing that. So that's just my opinion. I apologize for, but having tried to get, many, many years of clinician physician, physician assistant, nursing trainings for data capture.
Yes.
This
That,
is
the day is here. That could be semi-automated,
this is
reducing time,
promising.
improving
Yeah.
accuracy. Very promising.
Oh, you do not know how many pregnant male patients are in databases and systems
Oh,
around the
yes.
world.
Yeah,
So,
yeah. AI could certainly make that
yeah, so
a mistake, but it could learn from the
you can learn
mistake
not to do.
and
Yeah,
going
so
forward, not make that mistake again.
yeah,
That is the
thank
beauty of technology.
yeah. So I do want to turn over to my fantastic colleague Courtney, because again, I want to keep things very positive around this topic and engaging. So please do give your presence and time to Courtney on this very interesting topic. Okay. Over to you. And you're on mute, sorry.
Thank you. Rookie mistake. I'm going to go ahead and share my screen. Okay, hopefully that's working. Well, I'm so excited to be here today. I guess we're going to take a little bit of a 180-degree turn and see things on the brighter side as we close out today. Just a little bit before we start, as Bobby said, we've known each other for many, many years. I started work in international development over 30 years ago. Back in the former Soviet Union doing USAID funded reproductive health programs. And I've been in this space for many, many years. And as a hybrid, I also do stand-up comedy, and I have studied at places like Second City and DC Improv and other places. So my work is about combining those two spaces. And I'm also actually an executive recruiter in the nonprofit and purpose space. So my work is all about building resilient, impactful, healthy teams and organizations. And that's both from bringing on the right teams to helping them be the most impactful and healthy and resilient they can be. And so I'm here today from the mental health perspective and thinking of World Mental Health Day with a focus on mental health in the workplace. And why are we talking about humor and laughter in this very serious space? Because obviously mental health is not a laughing matter, but humor and laughter can be helpful, very, very helpful in addressing mental health issues. And that's what I'd like to talk about today. But first, I'd like to spend a second, let's all kind of get in the mood and see, just feel for ourselves the benefit of laughter and humor. And we're just going to laugh and giggle in our own heads or at our own desks about something we saw, heard, or anything that you think it was funny or peculiar or odd. I have mine that I kind of carry around in my back pocket. They may have happened a long time ago, but it can be something that you yourself did that was funny. Like a while ago, had just started dating someone. I saw him on the street and I was kind of saying, hey, call me, call me. And I walked right into a stop sign. So being really cool can be something funny that your kids said. It can be something peculiar you saw. I was walking down the street the other day, and this is a little ironic. I saw a guy on one of the shared scooters in a full clown suit. I thought, wow. And it made me think a lot about where is he going? What is he doing? And so just take a second to think of it. It could be an inside joke, something that a comedian said that makes you giggle to yourself. And just take a second to do that. Feel free to share them in the chat. And what I want to ask you now to think about, and again, you can share this in the chat, is how do you feel when you laugh? How did you feel when you just took your mind for a second off of the serious, off of what you've got to do next, the other things, to dive into your head and think about something that made you smile? And did that make you smile? And how does that make you feel? And how does it make you feel when you see other people laughing? And just take a second to think about that, because those feelings are really what's at the heart of why humor and laughter are so important for our mental health. So that's what I'm going to talk about. What does humor and laughter have to do with mental health? And what does that mean in an international context? I mean, we're here with Sid after all, and Dr. Jerome, thank you, from USAID, and Ting, who's doing amazing work all over the world as well. And what role can humor and laughter play in conflict zones? Bobby, you just asked about this also. And we can take this more, not just conflict zone, Jerome was talking about mental health in climate crisis. So really, what role can humor and laughter play in adversity and adverse situations? And then let's bring it down to what humor and laughter in an international development context. So those are the things I'd like to cover. So first, I want to dive into the science a little bit about laughter and humor. So laughter is a human emotion. We all laugh. And laughter is actually the only human emotion that engages every single part of our brains. These are real human MRIs of people laughing. And so you can see how it's really lighting up the brain all over the place. Well, why does that matter? And what does that have to do with our mental health? Because as all of that is happening, laughter is releasing dopamine and endorphins, where we experience pleasure and reward. It's stimulating our prefrontal cortex, which is where we have our social behavior and engagement, and our cognitive functions as well. It activates our amygdala, where we do our emotional processing and learning. Triggers the release of oxytocin, which is called the love hormone, which is what creates that bond. It lowers our blood pressure. It is scientifically shown to be related to overall better health, stronger immune systems, less illnesses. Workers who've been studied in workplaces that are known or reported to be happy and where there's a lot of laughter have fewer sick days. And it's contagious physiologically. So there's tons of science behind this. There's lots of research. And if any of you want to geek out with me later on that, I'd be happy to do it. I could talk about it for hours. But I was recently, for instance, reading a meta-analysis that the NIH did during COVID. And they studied thousands of different studies about humor and laughter, and they came to the conclusion that laughter therapy, which is a form of therapy used to address mental health, as well as other physical health conditions, and general humor and laughter are effective scientifically at dealing with anxiety and depression. And so they recommended the use of those during COVID-19. It's out there, the science is proving it. So this is, I stole from Jerome's presentation as he was talking, but just thinking about laughter and humor and mental health, laughter addresses all of these things: our emotional, our cognitive, our psychological state of mind, our overall well-being, how we think, feel. When you think about how you feel when you laugh, it's because all of that's happening in your body. You actually feel better. And we make how we make decisions, because we're more aware, cognitively aware, and we're also more creative and more open when we laugh. So that's the science. The other important part of the science, and this goes to not only how it's useful in mental health, but also how it's useful in an international context, and that is that humor is universal. So when somebody says, oh, she doesn't have a sense of humor, I don't have a sense of humor, actually, you're born with a sense of humor. So you do. Of course, your sense of humor is unique to your personality, to your experiences, to your culture, to all of that. But we all have a sense of humor, and that's important to know that that is a plane upon which we can all actually relate. So even if we don't share experiences and might not get somebody's sense of humor, we can still relate to them. When they laugh, we're going to laugh because we're mimickers and we have a sense of humor. When they smile, we're going to smile. When they tell us a joke, we're going to engage our brain and try to follow what they're saying. What's the punchline? If we don't get it, it provides an opportunity to ask. And then you get a whole story. Like, I see you thought that was funny. I totally don't get it. Oh, well, where we come from, our aunties always do this and it makes us laugh when X, Y, Z. And now you've learned something new. And also contextually, when you're together, no matter what culture or whatever you're from, when you're together, you're having shared experiences. And a lot of those shared experiences are absurd or funny, a loud noise, a weird thing happened, somebody spilled something, anything. And those become shared things you can laugh and have a sense of humor about. And we can intentionally hone our sense of humor, and we can bring out our humor and learn how to do that and use it intentionally. I just want to say I did a workshop with an international group from Special Olympics. So it was people from all over the world, all different parts of the organization, athletes, finance people, and all different intellectual levels of ability and disability. And we used humor through the whole day, and it was so powerful. They came up with some of the funniest jokes, but they also created a lot of new inside jokes and ways to relate with one another. So it is truly universal. So now that we know some of the science, what it does for our mental health, what about humor and conflict? Obviously, war is not funny. Suffering is not funny. Climate disaster is not funny. Starvation, none of the issues, mental health is not funny. But we have throughout history used humor because of its biological and physiological effects. It relaxes us. It reduces stress. It improves our mood. It creates unique bonds between us. It's used as a natural survival mechanism because it is a biological survival mechanism. And it enables us to step back and see the absurdities. So think about just even basic times of conflict when you had a disaster proposal you were working on all night, and you're all up there all night and you're working and your coffee, there's something funny happening and you're laughing your way through it. This is the same thing that comes out. I just read a beautiful article about humor in Ukraine and how it's bringing people together, how they've created these inside jokes that have gone viral and are helping people have solidarity to unite and feel together and survive. So the last thing I want to talk about is humor and laughter in international development. As Jerome pointed out, I mean, the need to address mental health as you can't address health without addressing mental health. You can't address economic development without addressing mental health. All of the issues, education, everything he pointed out, and that's a big part of what USAID is doing. The component I want to focus on is that USAID, WHO, UN, all these organizations, partners in health, are employing teams of expats, of nationals, of locals who are there to implement these initiatives, and they too have very specific mental health needs. There's a lot of stress. Oftentimes, if you start a new USAID project, you've got 3 subcontractors, plus your new local partners, plus you've got to please the local government, plus the donor, and you're all starting together, you've never met. And if that team can't come together, when stuff happens, I led the startup of an Afghanistan program in reproductive health way back when. And we had that same situation, and we had a bombing outside the office. People's lives are at stake. And if those teams aren't together and working well, have a safe environment, that workplace has to be safe when they come in from the field. It has to be a place where they can unload and have shared laughter and feel safety, and build resilience, and also learn how to work together and communicate in very positive and effective ways. And this is where leaders and teams who build in humor and laughter can be really powerful in that context. So just a couple tips to think about. Bobby, you mentioned at the beginning, what can I do right now? There are some simple ways to start doing this. Just start taking notice of things that are funny or happening around you all the time and share them. Did you just see that? Or this morning as I was coming into the office, the funniest thing happened. Share them and you'll start to experience them more. And then somebody you tell that to will say, oh, well, you should have heard about my morning, and you'll get to know them, and you can start bringing humor and laughter into your life. Try self-deprecating humor, always very, very effective, very safe. Share something funny you did that morning. Find opportunities for inside jokes. I just saw someone I worked with 10 years ago. I hadn't seen him since. And we looked at each other. We both said the same thing. It was our inside joke. And it was like we had never been apart, and it had been a decade. Listen, watch, read, share things that you find funny or amusing or curious. I'm thinking about digital solutions to mental health. How about things that are funny? Watching a few things that are funny. They have a lot of research on just watching 10 minutes of funny or listening to 10 minutes of funny will automatically reduce your stress, reduce your blood pressure, make you more relaxed, and have a positive health effect. So that's it for me today. Laughing really does matter.
Great for that. Thank you, Courtney, for keeping things uplifting, positive, because we know that this is a very serious topic, but I also appreciate that, bringing that lens of positivity is helpful. So what I'd like to do now is bring everyone together. So Jerome, Courtney, Tang as well. Julie, I think we had like 2 questions that weren't covered earlier. Also, if you have questions for Courtney or Tang, please put them in the chat. But I do want to leave 2 minutes for each panelist to leave the participants with 2 takeaway points. And those 2 takeaway points should address what can they do as individuals? What's your call to action as an individual that you would like to see them as? Because I'm like to not use a shovel and tell you what to do. I like to use a rake, and here are things I can do, and here's what I've shared. So that for me is my metaphor. So being able to say, as an individual, what are the things I can do? And then as an organization, what can my organization do? So I just want the panelists to think about those 2 things. And then Julie, if you can share at least 2 of the questions that we didn't cover from earlier or that I missed.
Yeah.
Thank you.
Sure. Okay, I think these were the last ones. There might be one more, but I'll just go ahead because there's 3 up here. How do we facilitate transition of services from inpatient to outpatient MH in the context of constrained budgets? Is there a model of efficient and effective outpatient MH worth replicating? Next question from Amy Chin. Because culture change takes time, how is USAID working with IPs to measure and monitor reduction of stigma on projects with mental health integration? And then finally, Kate Bunting, who's also on the board. How do you envision MH being funded? Only through integration with existing funding lines? Those were those were
okay. Those sound like Jerome questions. Go ahead.
I was going to say, Courtney, you want to take those? Because I'll start, but it's self-deprecating. After I assured everybody multiple times I wouldn't run over, I did. So I kind of don't want to talk much more. I will be brief. This first question is so important because it comes up over and over. I will just say that it's more like strategies than it is a specific recipe, a one size fits all, and it involves task shifting. That is to say, what are things that I'm doing that somebody else could really do? And task sharing. How do we share tasks? And that is one way to expand tasks. That could include training, not just physicians, but nurses or other personnel. HIV counselors do counseling already. Maybe they could do mental health screening and training, and those sorts of things. It can include the introduction of digital health, chatbots and stuff like that. So there are models, but they all rely on these basic concepts of task shifting and task sharing, moving out of this paradigm that mental health services can only be delivered by specialized, licensed, and I'm licensed. Save me for more complex cases, and I will save the more complex cases for people with more training. So those are the major models. All of it requires, I think what makes this tricky is it involves training, for the most part, humans and competencies. The second question on stigma, I think, was this planted? Somebody read my mind, because this is so important. What I can say is there are validated instruments for measuring reduction of stigma. They're like attitudes questions, questionnaires. And in fact, I was just editing an activity, development of an activity And I said, well, how are you going to measure stigma change? It's so important. And I sent them a stigma measure. So I've been really encouraging the introduction of stigma change instruments in the work that we do. But that's one area. And then the last question, how do you envision mental health being funded? So I think no, I don't think it's through, existing lines, but I also think budgets have got to match the actual need. A lot of people even talk about, maybe I shouldn't say this, but I will, a PEPFAR for mental health. So it's, I mean, maybe this is a watershed moment and we need to be thinking even bigger. But I think there's expansion of current funding lines, integration with other platforms. What I didn't make the case of, because I already went over, is that if we prevent things, then we actually end up saving money in these other services. Bobby, you worked in HIV. Integrate mental health. Guess what? Adherence goes up. Guess what? There are less treatment failures. Guess what? There's a less burden on the system. So I think that there's cost savings that are built in if we were doing integration, better and expanding lines. I will stop there. So Courtney has a chance to talk.
What was the question to me? Are you asking me to talk about?
Oh, I saw right after a question for Courtney. There was a question under my questions, but for you.
Oh, sorry, I just am seeing that now. What are the resources tools for building skill and laughter that can be used across cultures? There are a lot that can be used across cultures. Part of it is actually starts with getting in touch with your own sense of humor. So that is about the basic thing of just I like to write down funny things I see. It's also just, instead of listening to the news for 10 minutes while you're showering or getting ready, throw on something funny. Put on a podcast that's funny. This actually, and I'm sure you would know this better than I, this actually already starts to change the mood that you have, but it also changes the mood you bring with you. So if you think about how you enter the workplace or enter your office or get on the Zoom call, if you've just spilled something and you're stressed and you treat it as if you're angry, that's the energy you bring. If you've just watched something funny and you spill something on yourself and you're like, well, explains my day, that's the energy you've brought. So you've already sort of starting to share that sense of humor, and you're already inviting that other person to participate, and you're also inviting them to take risks, to make mistakes, to have foibles, and providing a safe environment. So one, it starts with you. Two, the second thing is to start sharing it. So just try little things, start sharing funny things you saw with one other person or with your team, something that happens. Take opportunities when they arise. A funny noise happens during a meeting. Use that as an opportunity to be like, well, I wonder what they're building over there, clearly, whatever it is, because you've created a shared humorous moment. And now you're probably going to have an inside joke. And you're going to be able to use that with your team over and over again. In times of real stress, it's often the absurdity. So let the absurd be absurd, because when things are really rough, that's when we can shut down and we take it really personally. If you start to see things as absurd, because conflict, war, all these things are absurd. That's why it's used so frequently. But even in your day-to-day, when you're stressed out about something with your team, let it be absurd. Find the funny thing. Make fun of the client you're producing this for. Make fun of the fact that, like, oh my gosh, it's always due in like right before the holidays, right? Or whatever it is, just start noticing and taking advantage of the absurd.
Thank you for that, Courtney. We
Sorry, I'll
appreciate, because
stop.
we
I
have
could
like
talk for
3
hours.
No,
I'll
no.
stop, but I'm
No,
happy
no,
to
we've
chat with others about
Yeah.
concrete techniques. There's a lot.
So I just want to move on to Ting to give you an opportunity for your 1 minute takeaway, and then Jerome, and then we'll turn it over to Catherine to wrap us up.
Okay, wonderful. So here's what I can do. I've been programming since before AI was even known as AI more than 20 years ago. And there's just so many technologies, we call them vaporware sometimes. You know, they describe and try to deliver the world and then doesn't do anything to that extent. And they got a bunch of funding for a marketing webpage that tells you that they might be able to do that. So personal passion of mine is distilling the myth of technology and really getting down to, does it work? Does it not? Was it validated? Were there actual clinical experts who looked at it and said it worked? Just how do you distinguish between solution technology-wise that works and doesn't? Just a personal passion of mine to do. And then my organization is in many countries dealing with many different diseases, including mental health. If there's any way my organization can help partner with you, explore ways to work together, I'd be happy to connect and help tackle this global mental health challenge together.
Great, thank you. And Jerome?
My 1 minute, self-educate. Maybe that's learning about self-care. Maybe that's learning mental health first aid. Maybe that's asking a friend or coworker how they are and then saying, no, really, how are you? Maybe that's watching that Vikram Patel video. Maybe that's an evolution in language. Maybe instead of saying committed suicide, it's died by suicide. Or maybe sharing what you learned today with somebody else. So take one step. For the bigger picture, I would say advocate for systemic change. I hope I made the case that in global mental health, it is about individual services, but it really is a systems issue. And that's what workplace mental health really is too. So, yeah, you can advocate for structural changes at work. Over to you, Courtney.
All right, thank you for that. So we'll turn it over to Catherine for our final remarks. So thank each of the panelists, thank each of you for sharing and being present for this session. This is, really near and dear to our heart. So Catherine, over to you.
Yeah, I just want to echo Bobby's thanks. Thank you, Jerome, Courtney, Ting, and thank you, Bobby. This obviously struck a nerve with many. And I just want to comment on Courtney's cartoon that said that awful moment when you realize this is your circus and those are your monkeys. This is all of our circus and all of our monkeys. I don't know anyone who is not touched by mental health challenges in some way. And it's hard enough to cope when you have a lot of resources. It's unthinkable for me how people in under-resourced situations manage. And it's gratifying that so many are thinking about and working on this extremely important issue. So let's keep this conversation going. Just want to make sure everybody's aware of our upcoming events, which you can always see on our website and in our newsletter, which I hope you all get. If you do not get our newsletter, you can sign up on our website, and it has lots of good information. And I really hope to see you all at our annual dinner. We can continue the conversation. Thank you, everybody.
Thank you all for being with us. So please fill out this survey. It's appreciated. That way we'll have your support in doing these types of events in the future as well. So, again, thank you, each of you, for participating, interacting, and being present on this topic. And you've seen the emails and the LinkedIn from each of the panelists. So do please reach out. And that's all that I have. Thank you all. Thank you.